Dr. Holler, just before we get started, you want to make your slides full screen? Is that okay?
There we go. How's that?
Perfect. Okay. All right. Good morning, everyone. And we're just about to start our virtual cardiac rounds this morning. Our guest presenter is Dr. Jonathan Howlett. He's a clinical professor of medicine at the University of Calgary. He will be presenting on the new Canadian heart failure guidelines. Just came out. So what? Good morning, everyone, and it's all yours, Dr. Howlett.
Thank you very much. I hope you can hear me. Just speak up if there's a problem. Thank you very much. It's time to talk about the new Canadian heart failure guidelines. Although many people might be thinking, so what? It's just another guideline. There's hundreds of them out there. It's a busy world. We're in a pandemic. Maybe it doesn't matter. So let's talk about that briefly. First, of course, these are my speaker disclosures. I will be using generic names. I'll try to keep it as objective as possible, but some of what I have is published evidence, and a little bit at the end is opinion and experience. So you're going to have to take what I say at face value or with a grain of salt per se, depending on how that goes. I'm going to briefly begin by talking about what heart failure is. This is something people tend to forget, and they think they know uh, what everyone else is talking about, and it's not always the same thing. We'll talk about the heart failure guidelines themselves. I'm just going to give you some highlights and go over the new things, and then perhaps a framework to outline where we're going. Please keep in mind that heart failure is a big deal. It affects someone that almost all of you know. It's a 20% lifetime prevalence, whether you're a man or a woman. That's twice as likely as breast cancer if you're a woman. And the prognosis is worse than most cancers. So, approximately 50% of people who are hospitalized for heart failure will be dead within 3 years. And about 50% of people who are diagnosed with heart failure as an outpatient will be either dead or hospitalized within 2 years. So, very, very high burden. And there's a lot that we can do about it. It's typically, in terms of diseases, it's either number one or number two. Most people don't think that giving birth is actually a disease. So COPD and heart failure sort of duke it out. We've had some gains early on. If you look at heart failure hospitalizations and the burden, these are American data, but the Canadian data is somewhat similar, although not quite as recent. The slide here just looks a little bit nicer, which is why I used it. It's from the JAMA Cardiology, and you can see that it was flat for a while, and then it began to grow back again. It came. It's kind of like a second wave, if you will, and we are now in a growth phase driven by younger people, driven by our older population as well, so sort of two-pronged approach to that, and also driven by diabetes, obesity, and a resurgence in hypertension. So that's a real problem. But what is heart failure? What you think is heart failure might not be the same as other people. And believe it or not, the large societies have argued about this for 40, 50 years. What is it? How do we diagnose this? It's easy to do when you see a big bag of a left ventricle that doesn't pump blood and has a low ejection fraction. But most people who present with heart failure, more than half of them don't have that. And so, how do you differentiate someone who's breathless with the multitude of other causes? And so here's the basics of how we do it. You need three things: the top two, and then one of the bottom. The top two are signs or symptoms of heart failure, the Framingham criteria, shortness of breath, edema. It's about too much water by symptoms, dyspnea usually, and it's too much water by examination, RALS, edema, JVP. And then you have to have something wrong with the heart, because there's lots of reasons for people to have edema and to be short of breath. So you have to have a demonstrable cardiac abnormality on some sort of imaging test. And then you need objective evidence that they're actually in a congested state. If without the bottom, all they have is an abnormal cardiovascular system. But with the bottom, either elevated natriuretic peptides or objective evidence of pulmonary congestion, like a pressure, like a chest x-ray, like a clear improvement with diuresis, stuff like that. Without those, you don't have the heart failure syndrome, because heart failure is actually a symptomatic condition. It's a collection of findings. So you need the top two and then one of the bottom. And then there's different types of heart failure. So so-called old stage A by the AHA staging is gone. It's now you're at risk for heart failure. People can go directly from this to heart failure without having had a heart attack, for example. So the common things, these are the neighborhood friends: hypertension, cardiovascular disease, cerebrovascular disease, diabetes, obesity, cardiotoxins like cancer therapies or alcohol or other drugs. People who have an abnormal cardiac substrate, LVH, they have a valve disease, they have a low ejection fraction, they have left ventricular hypertrophy or left atrial hypertrophy. These people have pre-heart failure. They have something that's demonstrably wrong, but it all isn't put together into the heart failure syndrome, which is stage C. And then finally, there's advanced heart failure that we won't talk much about today. And then when we categorize the kind of heart failure, so now we're into actual heart failure or advanced heart failure, it can happen with any degree of left ventricular ejection fraction. The one that we have all of the evidence for and that we're going to talk about for the rest is the top, heart failure with low ejection fraction less than 40%. This is where we've had almost all of our gains for treatment. But remember that more than half have combined either mildly reduced, 40 to 49%, or preserved, which is over 50%. These are the ones that are harder to diagnose. There's a new category, heart failure with improved ejection fraction, and this is a direct result of all of the successes we've had in treatment with HFrEF, because you can't have heart failure with improved EF on the very bottom unless you've had a low EF first. And then it has to go above 40, and it has to increase by 10 points. That's heart failure with improved EF. And with modern heart failure therapy, this happens to a large percentage of patients, probably more than half of your patients, if you're using modern treatments. We've had different guideline updates. 2017, we cleaned up several years of updates into a nice, tidy collection that was easy to find. We did a short update in 2020 because of huge advances, especially the SGLT inhibition. And then this year, we have the new updated standard that focuses on reduced ejection fraction, and it's a bit of a change, and I think you'll agree with me. This is what we had before. We were the first in the world to recommend triple therapy for low EF. That is a beta blocker, an ACE inhibitor, and an MRA. And then after that was done, we would reassess them and then maybe add further therapy. So kind of a stepped therapy, if you will. And now we have a new paradigm, and I'll show you what I mean. Number one, there was a big inpatient heart failure trial called Pioneer. In this trial, patients were randomized to either changing their ACE inhibitor to an ARNI, or if they came in not on an ACE inhibitor, to starting an ARNI or an ACE inhibitor. About 1,000 patients. This was an inpatient, low ejection fraction trial. They were brought in, and within a few days, they were stabilized, randomized, and the primary endpoint on the left, you can see, was a drop in BNP. BNP is an objective measurement of congestion. So we see that these people were decongested more efficiently when they were switched to sacubitril/valsartan. That's what the ARNI is, SV. And then after the first 8 weeks of the trial, everybody went on the SV, and sure enough, the ACE inhibitor patients caught up. Now, this is really important because look on the right panel. On the right panel were rehospitalizations. These were a collection of events, but almost exclusively driven by repeat hospitalization. And you can see there that there was an early improvement in rehospitalization. This is the first time this has been shown in an acute heart failure trial. And we've tried hundreds of times, and we've never come up with it until now. And notice that when they were switched, all of them, over to the ARNI after the 8 weeks, they became parallel. They did not catch up. And this curve actually persisted out for a year. So those early gains were not lost. We've now had not one, but 2 landmark trials of low ejection fraction patients treated with SGLT inhibition in addition to triple therapy, irrespective of dose, irrespective of drug, irrespective of setting, and it all showed the same thing. Both of these drugs, 25% reduction in morbidity and mortality. Very important. And we know now that we've had at least 5 different types of agents. These are not 5 different drugs, these are 5 different classes of drugs. So we're beginning to understand treating heart failure is like cancer chemotherapy. You treat one drug for this, one drug for that. They have different mechanisms of action, they do something different, and they all combine to be synergistic, as you can see here. This is outpatient heart failure mortality, not inpatient mortality. This is outpatient mortality. And you can see we are now decreasing the mortality in patients by over 75% by adding an ACE or an ARB, changing it to an ARNI triple therapy 5.6. Foundational therapy adds an SGLT to that, and we can further introduce that into that group of patients whose heart rates don't come down with the beta blocker and are added a sinus node inhibitor, SNI, otherwise known as ivabradine. And so that's a heart rate lowering drug. Now you see the most commonly used therapy in Canada is actually the brown or amber, not amber, but brown or tan line on the bottom. And event-free survival on the left is for hospitalization or death. Overall survival is in the middle panel. And then on the right is a Kaplan-Meier curve that shows, or sorry, a survival curve that shows how quickly these events diverge. Look in the upper left of that. And what you're finding is that the most common therapy that we are currently getting for patients with low EF and heart failure in Canada, the most common patient it's going to be just an ACE and a beta blocker, not an MRA, not an ARNI, not an SGLT inhibitor, but just an ACE and a beta blocker, and that's the lower level. If you switch that to modern quadruple therapy, so that's what we have now, and that's with an ARNI, that's sacubitril/valsartan, a beta blocker, an MRA, and an SGLT, look what happens. You get 8 extra years of event-free survival. If you're 55, if you're 85, you still get 2.5 years. And if you're for overall survival, you're getting 6 years. So people with heart failure over the age of 50, they lose 14 years of life expectancy, and they get half of them back, not by treating them, but by simply changing them from what most people in Canada are getting right now to what modern therapy should be. You get half of that back. So tremendous gains. We have additional gains too. We just wanted to show you here that every beat counts in your heart rate. If the heart rate is too fast, if it's over 77 beats per minute, that is too fast. If it's over 70, that's a little too fast. If it's over 77 and in sinus rhythm, that's way too fast. Mortality rises quickly when you're in that high heart rate. And look what happens when you add ivabradine to people who are already on a beta blocker, who are already on good therapy, and who already have a high heart rate. You can see that their ejection fraction goes up. The average is about 3%. That's more than an ACE inhibitor would have done. And survival improves. In fact, the number needed to treat if the heart rate's over 77 is only about 20 to save 1 life for 1 year. So very favorable effects. So we have the new guidelines. What does it all mean? Well, I'm just going to show you the key recommendations that we have here. So this recommendation that you see here, it's a new recommendation. We recommend now for people with low EF that they be on one drug from each of these categories. Quadruple therapy, foundational therapy is what I call it, ARNI, beta blocker, MRA, and SGLT. You say, well, why just these 4? Well, the reason is that most people tolerate them, most people are eligible for them, and all patients will synergistically improve. So any combination of these drugs that you care to put together will be better than if they're not on them. And it doesn't matter which one. So you use all of them if you can. And if you can't use one of them, the other three will still improve. That's why we call it foundational therapy. This is a new recommendation. The second recommendation is that we should use drugs that have been proven. So if you can see on the left, notice that in chronic ambulatory heart failure, all those classes of drugs, so sacubitril/valsartan, ACE, beta blocker, MRA, SGLT, and ivabradine all have high level of evidence. The 3 on the bottom we won't talk much about today. We don't have time, but they are the second line therapies that we'll talk about very briefly in a few minutes. Notice that in new onset, fewer of these drugs have excellent evidence. And for inpatients, very few of them have good data for inpatients. So the little crosses, by the way, That tells you that those were not based on a randomized trial. That's just because these drugs have been around for so long that we've seen these results from observational data. So this is not a new recommendation. We're just saying use the drugs that have been proven and try to get them to the doses that you want. The next one is ARNIs. The recommendations for ARNIs are different. So on the top, we recommend an ARNI be used instead of an ACE or an ARB in patients who are already on medical therapy. We've known that for a long time. That recommendation's been out. But the next two are new. The first one is that patients who are admitted to hospital with a low EF should be switched from their ACE to an ARNI because we know it's better. It reduces their congestion, it reduces rehospitalization, and that's durable. The number needed to treat, by the way, for that is only about 15. And then on the bottom, even if they're on no ACE at all, going straight to an ARNI is it's a weak recommendation, but it's a reasonable thing to do. So that's upfront ARNI therapy. And then we have the old beta blocker on the right. Basically, anybody with an EF under 40. We have on the top left, we have ACEs and ARBs. They'll still be, remember, about 10 to 20% of patients will be able to tolerate an ACE, but will not be able to tolerate an ARNI. So there still is a place for ACE inhibitors. It's just that they're no longer the preferred therapy. They have been supplanted. MRA, also, people forget about that. And in Canada, we lag behind the rest of the world for use of MRAs. MRA basically spironolactone, for those of you who don't do this a lot. These aren't new recommendations, though. And then the SGLT recommendations are all relatively, they're relatively new. On the top, you see, we recommend an SGLT inhibitor for patients with or without type 2 diabetes to treat heart failure with reduced ejection fraction. That's because of what I just showed you. Number 12, we recommend that they be used for treatment with type 2 diabetes and risk factors to reduce the risk of heart failure, hospitalization, and death. So that's for patients who have atherosclerotic disease to reduce the likelihood of heart failure and to reduce the risk of death. You've probably known that for a while too. We reduce to reduce the heart failure option for patients who have just risk factors with diabetes is our recommendation number 13, also not new. And then on the bottom, we're actually, a lot of people know that that SGLT inhibitors reduce the likelihood of renal progression in patients with diabetes, but a lot of people don't know that they also reduce the risk of heart failure as well. These are all continuing. And then we have ivabradine. Ivabradine is recommended by our guidelines committee for the use in heart rates over 70 to reduce heart failure hospitalization and death together. We decided to use the heart rate of 70 instead of 77 because we thought it would include more patients. There's a mortality benefit when the heart rate's over 77, and a lot of people focus on that because it's the Canadian label and it's how to get it reimbursed. But it is recommended by the guidelines for over 70 because there is a hospitalization benefit. There's a new drug called vericiguat that I'm not going to talk about very much because it's not yet available. It is a oral soluble guanylate cyclase inhibitor, stimulator. It works somewhat like nitrates, but it's not a nitrate. It's more predictable than a nitrate. It's better tolerated than a nitrate, and it also reduces hospitalizations in very high-risk individuals. Digoxin is also an additional therapy for patients who have ongoing symptoms despite medical therapy, and then hydralazine nitrates still maintains its place when you cannot take an ACE or an ARB or an ARNI because of kidney disease. These are all existing recommendations. So this is our new algorithm. You start on the top and you go with 4 therapies. Notice, foundational therapy is first. 4 of them. It doesn't say what order. And they're all horizontal with each other. The next step is after you have initiated those 4 drugs and titrated them, then you look for personalized therapies that are less often used. Ivabradine is only going to be used about 10% of the time. That's the size. Vericiguat will, when it becomes available, will only be used for people who've had a worsening heart failure hospitalization. Somebody needs to mute themselves in the background. for the hydralazine nitrates, it's for niche populations, as is digoxin. And then, and only then, do we recheck the ejection fraction. So we recheck the ejection fraction just once. And then we look for whether we should refer them for device therapy. So after the titration of the guideline-directed medical therapy, within 3 to 6 months, a decision has to be made. Do we refer them for device therapy or don't we? And it depends on the response to the ejection fraction, which is why you need to reassess the ejection fraction 3 to 6 months later. This is an algorithm that was put in the same issue of the CJC, Canadian Journal of Cardiology, where our guidelines showed up. And it just shows you, you go to foundational therapy, you go to the personalized therapies, you achieve medical therapy. After 3 to 6 months, you recheck the ejection fraction, and then for the device. And I'm going to talk about one trial. I'm not going to talk about the second one, but just the first one. This is another interesting inpatient study of an SGLT inhibitor. A lot of people say, should you give an SGLT inhibitor for patients in hospital? Well, if you look at this study, you would say yes, because this was a patient, this was over 1,000 patients. They were in a hospital. They all had diabetes. They all had heart failure. About 10% of them, or actually 20% of them, had an ejection fraction over 40 even. And they were randomized late in their hospitalization to either nothing, placebo that is, or sotagliflozin, which is an SGLT inhibitor, type 1 and 2. It's a dual inhibitor that's not available in Canada. Probably won't be. And notice that there was a reduction in hospitalizations, very impressive. However, don't forget, this study was stopped because of COVID. The primary endpoint had to be modified because they wanted to make sure that there were enough endpoints. All of the patients were diabetic, so it didn't apply to non-diabetic patients. And the outcomes were not adjudicated just based on investigator reports. So there were some irregularities with the trial. It's not a perfect trial. It's interesting. It's a real groundbreaker. Definitely, this is a safe drug, but it's currently being confirmed with other large ongoing therapies. So the result is that we have a lot of different, it can really be mind-boggling. And so what do you do when that's the case? All kinds of therapies, over 40,000 in the greater scheme of things of options. Well, keep in mind, time is of the essence. This is true for adding an SGLT, where you saw the primary endpoint. This is a regression curve for the hazard ratio. And you go a long time, and it's when the trial becomes positive. So that dark line is actually the estimate, the point estimate at any given time during the trial of what the benefit was. So if it was 1, there would have been no benefit, but it was below 1, so there is a benefit. And notice that it becomes statistically significant inside of a month. That's also true for beta blockers. It's true for the ARNI, and it's true for the MRA. All these drugs work quickly, and that's really important because you're leaving mortality and hospitalization on the table if you take your time starting these patients. And it's true for every outcome, whether it's worsening heart failure or in panel B, as you can see, which was the primary endpoint, or cardiovascular death. The trouble is, in the real world, this is what happens. This is from a Northeastern US registry. This is data just published a couple of years ago. We see people at baseline, and I don't know how many times I hear this. Well, we'll send them to clinic, we'll get them started on his drugs, and then we'll titrate them. But this is what happens. They don't get titrated. And not only that, they don't get started. You can see what happens after 12 months, almost nothing. There's about a 10% change from baseline to 12 months. And this isn't just in registries that you see here. It's not in primary care, but it's even in clinical trials where heart failure specialists were told to follow BNP and make changes to the medical therapy. Almost all medical therapy was finished titrating within 3 months. So people don't do much after 3 months anyway, even if they say they're going to do it. In heart failure clinics in Canada, it can frequently take a year if they stick at it. Most of that time seems to be spent frigging around with either a beta blocker dose or an ACE inhibitor dose before switching to the next drug, rather than just switching over to what's better or adding what's better to get a quicker benefit. So the 3 main takeaways from our guidelines and the recent studies are that it's now horizontal. It's not add ACE, then beta blocker, then MRA, then change it over to an ARNI, and then add an SGLT. It's all 4 of them, and we're not sure what the order is going to be, and I'm going to get to that in a few minutes. But it's horizontal. You start them on low doses. You do not maximize. So a little bit like using combination hypertensive drugs. The second one is let the patient tell you. If they have a low blood pressure, it's going to be hard to use certain drugs. If they have a high creatinine, it's going to be hard to use certain drugs. If they have a high heart rate, it's going to be easier to use certain drugs, so on and so forth. And the third is that time matters. I hope I've already made that point. Time does matter. And that means that we're going to have to change our way of thinking, not just from one drug, one visit. We're going to have to do more than one. And if you look at what we do in hospitals, if we can do this to a hospitalized patient, surely we can do this to an outpatient. There's a lot of algorithms out there. One of them by Greg Fonarow, he pushes on Twitter. He says, start them all at the same time, all 4 drugs. He's been an advocate for that. I'm gonna give you my own in a few minutes. There's another one by Milton Packer and John McMurray where you start the beta blocker and the SGLT and then the ARNI and then the that's, to me, that's reminiscent of stepped therapy. And it requires 3 visits before they even get a taste of their foundational treatment. So what's the right? We don't know which is the right way. And I'll be the first to admit, nothing's been proven better. Left has not been proven better than right. And this is really timely because a white paper was brought out by the American College of Cardiology saying that we need to implement a framework to promote more rapid uptake of these drugs. And this is where the studies are going to go. How to get drugs on quickly, how do they work, how can we be more efficient? So in the same issue that the guidelines came out, we published a cluster scheme for heart failure medical therapy. So I'd like to compliment my colleagues, and I'd like to show it to you. So the first step is we decide what we have. What are our ingredients? And they are foundational therapy on the right and personalized therapy on the left. This is for low ejection fraction. And as I said before, foundational therapy are those 4 drugs. Why? Because most patients will be eligible for them. Most patients should be on them. Most patients can take them. And then we have personalized therapy. And these may be drugs that aren't for everybody. Not everybody's got a high heart rate, for example. So not everyone's going to need a sinus node inhibitor. In fact, only about 10% will ever be eligible for that. Not everybody's going to have a great blood pressure and won't be able to tolerate. Not everybody's going to be iron deficient. Not everyone's going to have a tolerance of a soluble guanylate cyclase inhibitor. So these are personalized therapies, and they come generally later. But I am going to make some exceptions. And the reason is because we live in the real world and we have to make real decisions in front of us. And we have to have a cohesive way of approaching our patient. I've always been surprised and a little bit puzzled by the fact that we have all these fancy algorithms about how to treat this heart failure and how to treat that heart failure. And then there's no diuretic on. This is the first time I've talked about diuretic, right? Well, the diuretic has to be there, folks. You know this and I know this because that is actually the most common drug for a patient with heart failure is actually a diuretic. It's not any of these other ones I've been talking about. So how do you put that on there? Well, we use our framework and we say it works a little bit like an SGLT. Now, nobody knows how SGLTs work, but we do know that when you start them, they have a diuretic effect. So we're going to put them in with diuretic because we don't want to start a diuretic the same day that we start an SGLT. And we put them in the same cluster A. In the middle, 2 drugs that both affect creatinine and potassium, MRA and ARNI. ARNI also impacts blood pressure, but it's really their combined impact on potassium and creatinine where a lot of people would like to give them sequentially, maybe not on the same day. And this is where I disagree with Dr. Fonarow. I think it's better to give either an ARNI or an MRA, but not both on the same day. I would like to split them up by one visit. And then on the right, we have the heart rate drugs, the beta blocker and the sinus node inhibitor. Now, beta blockers lower blood pressure and they have other side effects. Sinus node inhibitors do not work unless you're in sinus rhythm. They do not work on paced patients. They do not work on atrial fibrillation patients. And then in the large type that you see, that's the preferred drug in each class when you're starting because they're part of the foundational therapies. You pick one during each visit from all 3. So it's like you go to the store and you go to the meat section, you go to the dairy section, you go to the vegetable section. Well, in the vegetable section, we have SGLTs and diuretics, and in the meat section, we have beta blockers and sinus node inhibitors. And you go and you take whatever you're going to use on that visit, and you do what makes sense for your patient based on their presentation. So the limiting factor over on the left is going to be intravascular volume. Dry patients, don't give them diuretics. Dry patients, Don't give them SGLTs. Wait till they're not dry. In the middle, it's going to mostly be potassium. That's really the big one, and to a lesser extent, blood pressure. And you'll have issues starting the ARNI. If potassium is your big issue, MRA tends to be a bigger issue. Don't forget, ARNIs don't raise potassium as much as ACE inhibitors do. A lot of people don't know that. And so those are the issues limiting here. And then on the right, of course, it's heart rate and then sometimes blood pressure, because even though blood pressures don't have an overall big impact on blood pressure, they do have an impact short term on blood pressure when you take the drug. So you have to be mindful of that. And you can make up to 3 changes, like I said, from each of these 3 clusters. The other change that we've made is hospital setting is not okay to use these drugs in the hospital. It's ideal. That's where you want to be. You can review these patients every day. You can see the very next day what their electrolytes are and their blood pressure, and you can make rapid changes when they're in hospital. So this is the place to start the drugs. And outpatient is also a great place to start drugs, but it's a lot less efficient because they're going to go home and you're not going to see them for a while. And then maybe they will get their blood work and maybe they won't. And it's not every 1 to 2 weeks. People, if you can change these drugs rapidly on an inpatient, you can't tell me that you can't do this to an outpatient, because you sure can. And certainly in the 30 years, that's what my observations have been. The other thing that we're going to change, and we've already seen this with COVID, I'm not going to talk too much about COVID. I live in Alberta, and it's, of course, Alberta's becoming a COVID king here. In-person appointments are not always necessary. Virtual medicine and remote monitoring devices are coming, whether you like them or not. We're not going to be able to show that they're better than routine care. I don't think that they are better than routine care, but they can actually replace routine care and be effective, cost-effective, and convenient. And then the monitoring parameters you see on the bottom are the same whether they're an inpatient or an outpatient. Time is of the essence, but don't use 2 medications from the same cluster. It'll just create a little bit of confusion if there's a problem. Tolerability will vary, and this is where we look at the different types of patients. This is what the cluster scheme looks like. We have A on the left, B in the middle, C on the right. We have red, which is usually a face-to-face. You want to get to know your patient after all. Blue can be face-to-face, or it can be virtual. And orange or yellow, whatever is coming in your screen, tends to be virtual. So who do we start? Well, there's 3 kinds of patients. There's 3 clusters, there's 3 kinds of patients. The ideal patient, they have good, reasonable kidney function, their blood pressure is over 110, and their heart rate's over 70, and they're not dry. Very important. These are ideal patients. You're looking to see if you can make a change in each of those 3. All 3. But then there's the person who's not ideal, but they're also not frail. They have 2 or 3 of them here, but not all of them. These are patients where you're probably going to use 2 changes, but not 3. And then you do have the frail patient where either 1 or 0 of these are present. These are patients that are difficult to titrate. You're not going to be making a million changes. You're going to be careful with these patients. There's a lot of them out there. They tend to be elderly. Not always. You can be young and frail. You can be elderly and non-frail. And it's really about what the patient looks like and their parameters. Here, you only make 1 change, and you base that change on their presentation. So here's an example. This is a person who saw his family physician, new onset of dyspnea, patient with type 2 diabetes, hypertension, dyslipidemia, sleep apnea, with a therapy for hypertension, and referred after this. And for those of you who don't read echoes, the chamber in the middle there, that's the left ventricle. It's hardly moving at all. The ejection fraction is under 20%. It just looks like it's jiggling. In the middle, that thing moving in the middle is the mitral valve opening and closing, and then underneath it is the left atrium. And then on the left side of your screen is the patient's right ventricle in the upper and the right ventricle on the lower. That's an apical view, an apical 4-chamber view of the echo, and it's a depressing echo to look at. So what did we do? Well, we noticed that when he came in, he was short of breath, he was functional class 3, and he was volume overloaded. He's got a good blood pressure, he's got a good heart rate, his JVP is over 5, he's got crackles, he's in heart failure. He's got a decent creatinine. So what do? Well, he's an ideal patient. So we start dapagliflozin here, we start sacubitril valsartan, and we start our beta blocker because we think he can tolerate it, and we think that it's okay. So We called him up, and sure enough, he lost weight. Remember, starting people on an ARNI will decongest them a little bit. People forget that. Starting them on an SGLT will decongest them a little bit. Starting them on the beta blocker will help. Notice his heart rate came down, but not by a whole lot. His blood pressure is fine. It's a little lower. He felt okay. His creatinine's good, and he's much better. So he's still an ideal patient. So what do we do? Well, we can't do anything on the left because he doesn't need a diuretic now. He's much better. Besides which, mildly volume overloaded patients are far easier to use these drugs on. We start spironolactone, 25 milligrams, because now that he's on his ARNI, we go, and now as of 2 weeks later, and we could have done it sooner, but we did this 2 weeks later, he's now on quadruple therapy. He's on foundational therapy. Now, not a lot of people are going to start ivabradine right away, and that's fine, as long as you're doing something. And so this person, they like their beta blocker. They were only on 3. Some of the beta blocker trials started them on a higher dose. Let's go to 6. So increase the carvedilol to 6. That's probably what most people do. No problem. You don't have to alternate. You just can alternate if you want. And then you follow them up. But then sometimes there's things that come up that change your initial choice. And this is the biggest deal here. There's in each cluster, there's one thing that really makes you change your mind. So people that are grossly volume overloaded, they're short of breath at rest, or they have a lot of orthopnea, and you really want to get volume out. These are the patients you're going to start on furosemide. This is what you're already doing in your clinics, and that's fine. That's the time where you're going to give them a diuretic first. They'll get them out of their trouble, and then you'll start the SGLT. If they're a little volume overloaded and they're not in trouble, I would have started the SGLT. But if they're having a lot of symptoms, they're quite volume overloaded, you need to get that volume out. The SGLT will not get them to lose 20 pounds of fluid. Furosemide will. For taking the sinus node inhibitor over the beta blocker, these are people who are very fast. Their heart rates are quite fast, and low blood pressure, beta blocker intolerance, heart block, active reactive airways disease, not COPD. People with COPD tolerate beta blockers, but active reactive airways disease or allergy to beta blocker, these are those patients where you are going to have to use something other than a beta blocker to start, or if they really had a problem with beta blocker intolerance. And that, folks, is going to be the big one. Instead of fighting with your patient with a borderline blood pressure or severe fatigue, and they can't take their beta blocker, and these are the kinds of people where adding a sinus node inhibitor is really going to make a difference right here, because they'll get that heart rate lowering and they'll feel better because they won't get the other side effects that the beta blocker gives you. Really makes a big difference in those patients who have a hard time with tolerating a beta blocker. And then people with low blood pressure, ARNIs are going to be harder. Remember, 10 to 20% of patients with an ACE or an ARB, they'll be okay, but they won't be able to take the ARNI. It's usually because of blood pressure. Keep that in mind. And the MRA is usually the choice for that. So let's take that guy then. He had a previous heart attack. He'd been switched to furosemide, and in the past, he really could only take 50 milligrams of metoprolol twice a day. He just could not tolerate a higher dose. He felt terrible, and even so, he had a high heart rate. This happens more often than you think. It's not the rule, it's the exception, but it does happen, and we need to recognize it. So he comes into your office this time. He's the same as the same case, just a few differences in his presentation. He's volume overloaded. He's functional class 3. He's got a good creatinine and a good potassium. So he's actually an ideal patient, but we already know that he had trouble with the beta blocker. So what do we do here? Well, this patient, we're going to stop the perindoprol. We're going to give him 2 days. We're going to start the ARNI because we know that that's the preferred drug. We're going to start dapagliflozin, and we're going to start ivabradine instead of fighting with the beta blocker. And that's because, and of course, he did quite well. Now, keep in mind, evidence for virtual care is all over the place. It's not high quality evidence a lot of times, but we are now beginning to see efficiencies. We're beginning to see that you can titrate control for blood pressure with better results. That with COVID, it's actually been one of the great equalizers, believe it or not. So in heart failure, as opposed to primary prevention, but in heart failure, the evidence in the US is that virtual visits increased and there was no disadvantage marginalized or racialized patients using virtual care for heart failure. So I'm just talking about the heart failure because I know there's been a lot of talk about disadvantaged populations not having access to virtual care, but in the heart failure population, that did not happen. So we're going to see more of this, and we're definitely going to try to figure out how to do that best. There's a lot to learn there. So I hope that I've made my case. This is, I think, my last slide. There are major changes with our guidelines. The new guidelines say quadruple therapy. It's horizontal, not vertical. Time is so important. Personalizing your therapies to patients is very important. And then my own takeaway is that multiple drugs, changing the way that we titrate, getting it more efficient, and really front loading the introduction of therapies and using an algorithm that you're used to make it easy, a framework that makes it a lot more reproducible, will really, I think, help us move this forward. So I hope that's been a benefit to you. And I'm happy to take questions or comments on either in the chat or verbally.
Thank you, Dr. Howlett, for that informative presentation. We'll go into the question and answer period. We'll leave it open for a couple of minutes. Like you said, you can either use the chat function or you can use the raise your hand function.
Are we allowed to just talk?
Go ahead.
Hey, Jason Burstein.
Hi.
Great talk. I caught part of it. I'll hopefully get the slides. I like the clusters of drugs. That's great. And then the balance with phenotype of the patient. Just a comment, and maybe you can add your perspective. So I'm an interventional cardiologist, but I do a lot of heart failure. And one of the things that drives me a little crazy is that everyone is so eager to send people for cath. I don't know if the guidelines comment, like, for example, that old guy with the crappy heart who clearly needed to be treated. Like my perspective, unless you have angina or you're an ACS with acute heart failure, my angiogram's so far down the road, but I find too often these people show up to the cath lab where everybody wants to look at their coronaries. I wonder if you could comment and if the guidelines talk about that at all.
Yes, this year doesn't. It's an update, and it really did limit itself to what I told you. But the 2017 guidelines does talk about that, and really, the role of angiography in heart failure is still debated. There is one trial, the Stitch trial. You're probably aware of it. That shows a fantastic mortality and a hospitalization benefit of revascularization for patients with EF under 35. But these were patients who were operative candidates. And to me, there's two reasons to do an angiogram for, forget about ACS. This is not an ACS talk, so I'm not talking about that. But for heart failure, there's really only two reasons. And the first is, if it's of critical importance to you to absolutely know if there's coronary disease, because that will affect how you treat secondary prevention, or if there's some sort of preoperative assessment that needs to be done, and you just need to know what that is. So that's fine. Okay, no problem. That's true for whether they have heart failure or not, right? Then, but the other one is, if you think they're a good operative candidate and you think they got multivessel coronary disease, well, then they might get a mortality benefit from surgery. But I agree with you. We get a lot of knee-jerk referrals. I work in the cath lab as well. In fact, I was in the cath lab yesterday, and 4 of the cases that I did were rule out CAD for somebody who showed up with an EF under 40. Okay, so I feel your pain, and so that knee jerk, send them for a cath to rule out coronary disease, I think needs a little bit more thought. And so, and especially, I can tell you that guy with the first echo, he was no operative candidate. Okay. I've seen operative candidates, and he wasn't one of them. And so I would not have cast that guy because he had, a bad heart and was frail. So sorry for the long answer, guys. But
no, that's good. I agree with you. And sometimes the biggest advantage is to seeing them is that it's a touch point. You could adjust their meds when you see them in the cath lab. You can get their EDP and blah, blah, blah. But I try to teach folks that, and also realize that, like, get them stronger, decompress them, get fluid off, get them on optimal medical therapy, and then rethink about it. It's too often just a reflexive mechanism. But anyhow, great talk. I enjoyed it. I'll have to go back and look at your slides more carefully. Good job.
Thank you very much.
Excellent. Anyone else have any questions for Dr. Howlett?
Yeah, Jonathan, it's Ash Mukherjee here. Can you talk
Hi,
a
Ash.
little bit about the role of BNP in long-term follow-up of your heart failure patients?
Yeah. So, well, you live in Ontario, so BNP is almost like a bad word in the hospital hierarchy, it seems. So there is a role. The most important role is to help make the diagnosis. That's where the most evidence is for BNP, but it is prognostic. And it can really help you when you're following your patients in certain situations. I do not routinely follow patients' BNP. I don't do it. I always have a reason to order it. So I don't, it's, you shouldn't just order it and say, okay, well, his BNP's down this month. Isn't that good? That's of minimal benefit. But it's in many provinces, you need a BNP to get access to medications. That's critical. B, it's particularly useful to help diagnose heart failure for patients with an EF over 40, because there's a lot of other things going on, and it's part of the diagnostic algorithm. And then C, for people who come in and you're not sure what's going on, that's where it's going to help you. And so someone comes in, they're not doing well, they have new symptoms, they're tired, they're short of breath, they're about to have heart surgery, any type of surgery, not just heart surgery. Those kinds of situations, that's where I would get a BNP to help me decide what I think is going on. So if someone's, maybe they're tired or their exercise tolerance has dropped, and I'm not sure what's going on, and then the BNP is doubled, that's important. So that would be my answer in terms of follow-up. Make sure you have a reason to do it for follow-up. It might be to get a drug covered. It might be to make the diagnosis. It might be to help you determine what's going on because you're not sure.
Great, thank you.
We'll leave it open for another 30 seconds. See if anyone else has any questions. Just a reminder, everyone, that this talk is being recorded, so it can be found on our archived website at the Cardiac Rounds. I usually upload them every 2 weeks.
I'll just ask another one. In an ideal world, timing for defibrillator, I think your talk said 3 to 6 months. In your personal experience, if you had, it's a real ideal situation, how long do we really have to wait, do you think?
Well, you need the medical therapy to give it a chance to work. And there are some nuances here. And remember, these are guidelines that are designed to be a kind of a blanket recommendation. So there's always exceptions to that, and please keep that in mind. But in the real world, 3 to 6 months after therapy really means 6 to 9 months for the most part. And you already know that. I could tell by the way you asked the question. And sometimes it's longer. Yeah. There is a difference too. There's more to it though. People with non-ischemic cardiomyopathies don't behave the same way as people who have ischemic cardiomyopathies. First off, ischemic cardiomyopathies have a much higher risk of sudden death as a factor of their death. So they're at higher risk. Secondly, people with ischemic heart failure, i.e. due to coronary disease, they don't tend to reverse remodel as much. There's not as many improved ejection fractions there. Yeah. And third is what reverse remodeling you get with ischemic heart disease tends to happen in the first 3 months. And you don't get a lot of late further benefit. And that's not the case with non-ischemics. So the dilated cardiomyopathy is what I'm talking about, non-ischemics. They can continue to improve longer. So most electrophysiologists, when they get referrals and it's a really low EF and they have, it's ischemic, some of them will book them for their defibrillator a little sooner because they're very pessimistic that the ejection fraction will improve. That's a debatable strategy, but some of them will do it that way. And that's why. I'm just explaining to you what their reasoning might be.
Yeah.
And they tend to go quicker. So I don't wait as long for my ischemics as I do for my non-ischemics. But for most people, if you want to remember a simple number, it's 3 to 6 months after you're done your titration, recheck the ejection fraction, because that's what's going to make the decision. I hope that made sense.
Yeah, no, that's great. And what do you guys out where you are at West? Do you guys do? What about the post MI? Do you guys stick to 45 days as per that
Yes.
whatever study it was? You guys still
Yes.
sticking to that? Yeah.
Yes, we do.
Yeah.
Yes, we
Okay.
do. That's a really key question, because there actually is a well done large randomized trial. It was called Dynamite,
Right.
DYN, and that trial actually trended to a worse outcome when you put the defibrillator in right away, as opposed to waiting. So
Right.
that's why that recommendation is there. It doesn't make sense. I have a hard time getting my head around it too, but there you have it. So definitely we do wait.
Okay. Well, that was helpful. Thanks.
Now, one last thing though, if they had late VT after their MI, all bets are off. Now you put it right in. Okay.
Yeah, I agree. Yes.
Yeah.
Yeah.
And by late VT, you mean more than
After
48
the
hours?
first, that's right. Exactly right. The first 48 hours is, you get a mulligan for that. Okay. Because it's an acute MI, and everybody knows that in acute MIs, you're allowed to have a little VT in the first 1 to 2 days. But after that, that's late VT. And that is secondary prevention, not primary prevention. And then you put it in right away.
Great talk, Dr. Hallett. This is Angela. I just have a question with respect to treatment of mid-range EF. I know you didn't have time to talk about that, but what are your thoughts in terms of role of SGLT2 and the MRAs and ARNIs in those subpopulation? And second question is, patients who come post-MI with heart failure, again, what are your thoughts on that, starting in those set of patient population?
Yeah, good question. So first off, patients with it's the term is now changed to mildly reduced ejection fraction as opposed to mid-range. So the European Society for Cardiology first coined this term in 2016, and they called it mid-range. It's not a mid-range. It's low. It's just mildly low. So that's what we're calling it. It looks like the balance of evidence now suggests that EFs between 40 and 50, especially between 45 and 50. So, but definitely between 40 and 50, that you can achieve a hospitalization benefit for sure with these same therapies, except for the beta blocker. Beta blockers there's really very little evidence that beta blockers do much of anything once the EF's over 40. But for the ACE, the ARB, for the ARNI, and for the MRA, there's evidence that they reduce hospitalizations up to around 50%, and that they're probably worth giving. In fact, the ARNI just got a recommendation. So I wrote an opinion piece in the same article as these guidelines that came out, talking about that, and the FDA has actually approved the sacubitril valsartan for ejection fractions 40 to 50. And that's to reduce hospitalizations. And I agree with that. The trouble there is, what's the cost effectiveness? And so that's a tougher decision, because you don't have a mortality benefit, you have a hospitalization benefit. SGLTs between 40 and 50, we simply don't know yet. Only a small number of patients in that SOLOIST trial that I showed you had an EF over 40. They seem to go in the same direction, but that's in an acute heart failure setting. There's one small mechanistic SGLT study in HEF that was published, didn't show much of anything at all. That was just published in the European Heart Journal. There are two large ongoing randomized trials of SGLT inhibitors in HFpEF, and we'll just have to stay tuned for that. But I would say that for non-diabetic patients who don't have proteinuric kidney disease, that if your EF is over 40, I don't think there's any big urgency to get them on an SGLT. I would try to get them on an ACE. I would try to get them on an MRA. I wouldn't try to get them on a beta blocker. And we can't, if the patient wants to pay for the ARNI, then that's fine, but it won't be covered over 40. So that's where I would go with SGLTs. I would focus on people with kidney disease in protein. I would focus on people with diabetes, and I would focus, of course, heart failure with reduced ejection fraction. Sorry for the long answer.
What was the study of MRA over 40? I can't remember that.
It
Oh,
was called TopCat.
yeah, that's right. And it was the difference depends where you lived in the world, right?
Yeah. So, well, the difference was how you got into the trial, actually. That's what it turned out to be. Because the people that were in Russia and Georgia, it turns out that one of the ways that people get medical care in those places is they volunteer for a research study and they get free medical care. And that's how they got in. That's how they got in, because these were patients who had hypertension. They didn't have heart failure. And we didn't know that at the time. So their BNPs were low. In North America, people were enrolled into the TopCat trial because of a high BNP as opposed to a hospitalization. In Russia and Georgia, they were almost exclusively enrolled because of the hospitalization, but they didn't really need to be hospitalized. They weren't really in heart failure. They were basically a high-risk hypertension group. So that's why you got those results. It's really unfortunate because we would have been a lot further ahead if we had kind of understood that trick ahead of time.
Right.
Good question.
All righty, everyone. Thank you for joining us this morning. Once again, thank you, Dr. Howlett, for the presentation this morning. And we'll see everyone back next Tuesday for next week's cardiac rounds. Thank you, everyone.
Very much, guys. Take care. Bye-bye.
Take care.